through a number of iterations over the years. He's also one of, I think, possibly, Bob, you may be the only ACLS certified rheumatologist that I've ever seen.
That's right.
So,
I'm an instructor.
yeah, that might be actually the most impressive thing on your CV. But anyway, I'll let you go ahead. But thank you very much for joining us, Bob.
Thank you, Yusuf. It's really a great pleasure to be back with my colleagues, former colleagues at St. Luke's Roosevelt, which was one of my most wonderful experiences in life, to be at both hospitals and do research and have such a wonderful division of rheumatology. And I'm going to start out, and you were too kind. The kinds of CVs and everything like that are, as you know, they come and they go. But my ACLS instructorship was actually something that I started when I was at St. Luke's Roosevelt. And I still continue as the medical director of emergency services for part of Bergen County. It's interesting. And I still ride the ambulance and go to codes. Not as many as I used to, but I still do go to the big motor vehicle accidents. It keeps my adrenaline going. Anyhow, let's begin. So I've been a consultant for GlaxoSmithKline and a speaker for GlaxoSmithKline, and they are the makers of belimumab. And I will be mentioning that particular biological towards the end of the talk. Systemic lupus, our goals here and the learning objectives are to explain the global nature, to show the clinical variations and presentations, to explain pathogenesis a little bit, discuss some new agents used in treatment. This is an overview slide from Joe Smolin's book, and I believe it's Carol Gordon's, the overview of the pathogenesis of lupus, which gives you an idea of how diffuse our understanding is of the pathogenesis of this disease. In the textbook, which is coming out in July, the 6th edition, we have a whole section devoted to pathogenesis. And nothing has changed very much. We now talk about inflammasomes, we talk about polymorphonuclear leukocyte contributions, etc. But here you see that the environment, hormones, genetic factors, stochastic factors, and initiation of pathogenesis all occur for reasons that are totally unclear. Dendritic cells, could it be defective priming, interferon secretion, T-independent antibody production, defective antigen presentation? We simply don't know. We do know that B cells are critical with increased activity in autoantibody production, which produces our wonderful array of antibodies, and that T cells are also involved, and there's a back and forth of increased co-stimulation and cytokine health. And then you get abnormal complement fixation, defective phagocyte activation, circulating complexes, etc., and then ultimately tissue damage. Now, the interesting thing here is that we still do not know what the triggering mechanism is, but we'll talk about that in a second. Here's another slide to illustrate the same thing. This is from our textbooks at, right up to 2004. You see when the slide is very, very complex, it indicates that the understanding of the disease is not very good. And I look at the top of this slide and you see drugs, ultraviolet light. Oops, I think I did something here. You see drugs, ultraviolet light. Let me go back here. Yes, infectious agents. We simply don't know. What we do know, and this is really interesting, with the onset of COVID, we are seeing many, many people who share autoantibodies, both men and women, who present clinically as though they have systemic lupus. And it's been published in the literature in Nature Medicine and a few other papers about the mimicry behind this rheumatic disease and post-COVID infections. Now, the amazing thing is that we know that viruses are probably a triggering mechanism for this disease, but we had no idea that we would see such mimicry and such altered cytokine production and abnormal gene transcription with the COVID or coronavirus. It's quite remarkable. There are 3 kinds of lupus: discoid, systemic, and drug-induced. The primary age of patients with lupus is in the early, between the ages, I suppose, of 18 to about 40, and mostly women. The gender preference is 10 times women for every man. The multiple elements in the immune, and I'm going to see if I can move this over. I'm trying to minimize, there we go. So adaptive immunity and innate immunity are involved, just as one sees with the viral infections. The role of dendritic cells, which you see here on the right of the screen, myelodendritic, plasmodendritic, macrophages, all producing cytokines. And over here, adaptive immunity, 3 days after the initial infection with B cells and T cells, the production again of cytokines, and in the fact of B cells going to plasma cells for autoantibodies with inflammation and tissue damage, which is really amazing. And here, despite improvements in survival rates, SLE remains a chronic disease with a higher than expected mortality. Now, I also want to comment on COVID-19 because we're seeing the similar kinds of long haul effects immunologically on patients that have COVID infection. So you'll see here that the cohorts diagnosed between 1950 and 79, which is the dotted gray line there, show that the mortality, the percent of patients surviving, plummets significantly. And then with increased knowledge between 1980 and 92, the orange dots show that, survival has increased. And it is, though it is significantly worse than in the general population, the survival is significantly improved from 50, 60 years ago. When I got into this business of studying lupus was in 1978. When I was a fellow with Henry Kunkel at Rockefeller University, my job was to take care of all the lupus patients in the research center. And essentially I did that. And the first textbook arrived in 1986. The rate of lupus mortality remains high relative to the general population. You see here, let me see if I can minimize
Bob, what we're seeing is fine, just so you're aware.
Because I have all of your pictures to the right of my screen. Okay, so the death rate is from 16 to 24 years of age with lupus is 19.2 times greater than the general population, and it continues to decrease actually. But even with the older age group, which I think is greater than 60, you see that the incidence is 1.4 times greater than the general population. And this is from the Systemic Lupus International Collaborating Clinics, or SLIC. We use SLIC all the time to look at mortality and morbidity with this particular condition. Cardiovascular events, malignancies, and infections are among the most common causes of death. Cardiovascular, the range of organ systems, and SLE mortality from 9,547 patients followed between 58 and 2001 showed that 1,255 deaths occurred. Patients have been followed in this slide for 76,948 person years. So the mortality rates are significantly higher because of renal causes, 5 times higher because of infections, and almost 2 times higher because of cardiovascular disease. And again, the morbidity and mortality, and this slide is from an Abu Dhabi conference that I gave a couple of years ago. Things have not changed. And what we're seeing with COVID is the same thing. Now, little facts about pediatric lupus. There are only 5,000 to 10,000 children with lupus in the United States. There are no worldwide compilations. The estimates of the disease incidence between the ages of 10 and 18 in the US are 31 cases per 100,000 Asian females, 20 cases per 100,000 Black females, 13 cases per 100,000 Hispanics, and 4 cases per 100,000 whites. So there is definitely an ethnic skew, which we see in the adult as well. Asians and African Americans tend to be the most affected by this particular autoimmune disease. And the reasons for that are not clear. ANA patterns, we can pass on this. Most of you know about the common autoantibodies, anti-double-stranded DNA associated with nephritis. That's key. Here, anti-Rho SSA seen with Sjögren's syndrome, but also seen in lupus. Anti-Ku, many of these are not available. Anti-histone, seen in many disorders, particularly drug-induced lupus, and anti-single-stranded DNA, which we don't advise anyone to order, is seen in just about everybody. Anti-Smith is a marker for SLE, and Stephanie Smith actually lived across the street from the Rockefeller University. She was a patient of Aang Tan's. Many of you of a certain age would remember Dr. Tan, who's in his 90s, mid-90s right now. She had a colorful history, and I still have her dried out sample, her lyophilized sample of sera in a freezer, believe it or not. Stephanie Smith, not smooth muscle. Antibody-specific syndromes. Well, the only thing the antibodies are good for, other than native DNA antibody, with which you can follow renal disease, is for classification. And for example, anti-Ro or SSA is associated with subacute cutaneous lupus, interstitial lung disease, homozygous C2 deficiency, Sjögren's, neonatal lupus, ITP, and primary biliary cirrhosis. Here you see a case of anti-Ro positivity in a patient with subacute cutaneous lupus. Pretty nasty. He had no complement. His C1q was normal, but C2 was gone. And this was associated with the presence of anti-Ro. And the desquamation that we see here is fairly common with this variant. So anti-Ro is very interesting. And many of these antibodies, like anti-Ro, SM, RNP, give us subgroups, much as we see in dermatomyositis and other conditions where the antibody speciation right now gives you clues as to what you're looking at. So the morbidity in children, actually this is morbidity of everybody, arthralgias, skin, constitutional, malaise and fatigue, renal disease, arthritis, Raynaud's, vasculitis, central nervous system, mucous membrane involvement, and of course, renal failure. This is from Murray Urowitz's Toronto cohort, lupus cohort. This is children with systemic lupus. To compare to what you just saw, not much difference, but in France and Toronto, there are differing numbers: anemia, leukopenia, musculoskeletal disease, fever in groups, renal disease. Patients, it's not unusual for patients to present for the first time with renal failure without any of the other comorbidities. And that's particularly noteworthy in the Black and Asian population. So it is unusual. Drug-induced lupus, the usual old drugs, isoniazid, procainamide, hydralazine. Then there are many, many new drugs. There must be over 50 of the new agents, including the TNF inhibitors like Remicade or hydralazine, that can actually produce a drug-induced syndrome. Favorite board question, actually, in rheumatology. There's usually no renal disease, and the disease is usually reversible when the offending drug is removed. Here is a contribution from Bruce Richardson, who just wrote the chapter for the 4th time for our 6th edition. This is an early slide from 2007, showing the methodology, which is largely based, he feels, on epigenetic influence, hypomethylation of DNA, for example, which causes increased expression of B cell EBV virus genes. Now, we could easily say that that could be similar to a COVID-19 infection causing epigenetic effects, and that may be how the virus affects the immune system. We simply don't know. But this is hypothetical. Hold on a second. Yep. These are the risk factors being environment, which we already have spoken of, tobacco, viral infection, COVID, possibly, EBV, CMV, silicone exposure, UV light, which we have no idea as to why 60% of lupus patients are sensitive to UV light and 40% are not. Microbiome of the gut, demethylating drugs giving or casting epigenetic effects to such patients. Then there's the genetics, which there are DR2 and DR3 on the histocompatibility gene, which increase the risk threefold. Complement deficiencies, of course, which we all know. Genetic risk loci, there are greater than 90 of these genes involved in the clearance of nuclear material. I apologize for the typo there. Didn't catch that. And then gender, one of the most interesting aspects, 10 to 15 times females more common than men. And what does that mean? Does that mean that the females are mounting a better immune response, a lesser immune response? We simply don't know. And then, of course, there's my Klinefelter patients. The Klinefelter patients have a 14 times risk of having autoimmune disease, not just lupus, making one think that the X chromosome is critically important to the acquisition of this disease. And those, the MECP2 and TLR, the toll-like receptor 7, et cetera, are kind of epigenetic in character. Now, the gender aspects, as I said, are interesting. Nobody knows why. Hormones play a role in modulation, but not in the etiology. The X chromosome can play a role if you look at our Klinefelter patients and say, well, look at that, 14 times the risk. And these are markers that are also associated with the disease itself. Estrogen metabolism is extremely important. We did early work in this at Rockefeller. 16 alpha metabolites, very estrogenic metabolism is associated with systemic lupus, but not the cause. It's also associated with breast cancer and liver disease. Hydroxylation in the 2 direction associated mostly with osteoporosis, hence the reason for postmenopausal osteoporosis likely, and the fact that that pathway is increased by thyroid hormone, vegetarian diets, athletic activity, particularly in young women, cigarette smoking, and the use of naloxone, of all things. I find this to be very interesting. This is data that's about 30, 40 years old that we produced when I was a fellow, and my God, it's still applicable. Here's a Klinefelter with lupus, and this guy was 55 years of age. You can see that he has acanthosis, he's a diabetic, severe SLE, pleuropericardial disease mostly, pleuropericardial disease, which is most commonly seen in the Klinefelter population. Gynecomastia, he was infertile, they couldn't have children, the wife wanted to know what was going on, finally he got karyotyped, and indeed he's an XXY. Genetic aspects I already mentioned, constitutive or just chromosome 6, we don't know. There's an HLA class 2 relationship, as I mentioned. Here you see class 2, class 3, class 1. The complement deficiencies are all bound up in that. You see chromosome 6 at the top of the screen. Complement deficiencies, C1q, C1r, C1s, all producing SLE-like disease. Now, I think we have a little bit more insight into why this might happen because of the role of complement in clearing immune complexes and the fact that post-viral infections and the formation of immune complexes, they may not be cleared. And if you're deficient, as is very common with C4 complement component, you'll wind up with a lupus-like illness. This is a patient, a very famous patient with homozygous C2 deficiency with an erythema multiforme kind of skin lesion, and she subsequently died at a fairly young age from her C2 deficiency. We see these C complement deficiencies, but they're not common. And fortunately, they're not. But when the CH50 is very low and the C3 and C4 are undetectable, then you think complement deficiency. These are some of the criteria. I'm going to pass over this fairly quickly for systemic lupus. We can come back to that if need be. The SLIC clinics, which from 2012 have both clinical and immunological indicators to classify patients with lupus. And you see all of these markers, which I will not read because you can see them on the screen. Most importantly, leukopenia, hemolytic anemia, alopecia, oral ulcers. And here's the immunological SLIC data. Now, these SLIC criteria are very important for the development of new biological drugs. And we go to the FDA with SLIC criteria and we show them various markers, SLIC being one of them, to show response, clinical response of, say, a biological, the biological, which I'll show you in a moment, which is belimumab, the monoclonal antibody against B lymphocyte stimulating factor. But here you have the need to have anti-Smith as one of the classification criteria, antiphospholipids, low complement, and direct Coombs test in the absence of hemolytic anemia. Renal disease, first, following lupus nephritis. Yusuf originally asked me to go into new treatments for renal disease, and I can't say, Yusuf, that there are many new treatments, although belimumab now, I've seen data to indicate that it is useful in the treatment of renal lupus. I'll show you some of that. Following lupus nephritis, we use native DNA antibody and complement component levels. That's the only two things that I get. Biopsies are very, very helpful. With crescents are more likely to be perinuclear, anti-neutrophilic, cytoplasmic antibody positive, usually not against myeloperoxidase. Here are the various classifications. You know this well. Minimal mesangial, no clinical findings, mesangial proliferative, microscopic hematuria and hypertension and proteinuria. We get to grade 3, which is focal, active, or chronic, hematuria, proteinuria, nephrotic syndrome, plus or minus hypertension, and of course, diffuse proliferative glomerulonephritis type 4, segmental global, segmental or global, and active or chronic. Very important based on the biopsy as to what kind of therapy we would be using to treat such patients as we go forward. And here you see the membranous type 5 nephropathy and type 6, which is advanced sclerosing. And clinically, the membranous advanced extensive proteinuria with minimal hematuria, renal function abnormalities, and of course, chronic kidney disease in the type 6. These two would have special methods of treatment. I'm not gonna, I'll pass over that. It's a lousy slide. Frank Netter, I tried to capture that. Frank Netter, the great illustrator who died many years ago, actually drew and painted the deposition, as you see, of immune complexes in these cartoons for the different kinds of nephropathy, but I couldn't get it to be crisp. I have to go back to the original drawings. The factors that can influence the prognosis of lupus nephropathy are, of course, your age, your sex, whether you're Black or Caucasian or Asian or Hispanic, the clinical aspects of renal involvement, the severity of the illness, the presence of hypertension, and the renal histology, which I just mentioned, whether there's an activity index that is decreased activity or increased activity and severity, or whether there's sclerosis and fibrosis of the glomerulus. All of that can influence what you do with your chemotherapy. And that is very, very clear. And it's useful by all nephrologists all of the time. Factors that can influence the prognosis, location of the deposits, whether they be subepithelial or subendothelial, capillary thrombosis indicating, yes, could be phospholipid syndrome related, the pathogenetic factors, the immunology of what's going on in the kidney, the type of immune complexes that are there, anti-double-stranded DNA antibodies, the complement activation, reticuloendothelial system dysfunction, namely the innate system, platelets and their function, and fibrinolytic abnormalities, all affecting the influence and prognosis of lupus nephritis. And again, I go to COVID, I back up to COVID. We've seen a lot of this in COVID patients, and hence our use of low-dose heparin early on to treat such patients to prevent capillary thrombosis, particularly in the lung, I might say, not just the kidney. Very interesting disease. The treatment of renal lupus right now, class 3 or 4, is IV methylprednisolone. I give industrial strength using the Cathcart protocol for 3 days. That's industrial strength being 1 gram per day for 3 days. And then I put the patient on mycophenolate mofetil, particularly if they're Black or Hispanic, which the data from Ellen Ginsler in Brooklyn indicates that CellCept is far as effective as Cytoxan. Patients who fail to respond to either of these are candidates for calcineurin inhibitors, Rituximab, which I use very frequently, or a combination of both. Class 5 renal nephritis, oral prednisone for 6 months, and mycophenolate mofetil, 2 to 3 grams a day for 6 months. That's class 5. And you can go to cyclophosphamide at any time. And I try to avoid use of cyclophosphamide when I can, but I can't guarantee that. When a patient's refractory to cyclophosphamide in lupus, I go to rituximab, which is very effective. Here are the Cytoxan protocols. There are many protocols that I use, and you can, David, you can take these slides and use these protocols. 15 to 30 minutes before the infusion, I give dexamethasone, 10 milligrams of lorazepam, 10 milligrams of dexa, lorazepam 1 milligram, Zofran 8 milligrams for nausea, and 100 milligrams of saline. And then I infuse 0.5 to 1 gram per meter squared in 1,000 milliliters of normal saline. I check the white count at 10 days to see if there's a nadir. I know my treatment is working if there's a nadir, and I reduce the dose by 0.25 grams per meter if the white count is less than 3,000. If it's greater than 4,000, the dose can be increased to 1 gram per meter squared. Now, in the old days with Henry Kunkel in the Rockefeller Clinic, I would put a butterfly in, have a 50 cc syringe, and push it in 15 minutes. And that was pretty interesting, because now we have all this stuff where we have to give all sorts of penumbral, Benadryl and Tylenol and all kinds of stuff. But in the old days, we didn't do that. We just pushed the Cytoxin in, and everybody was happy. The patient left the clinic, and we watched their white count over the 10-day period. Skin. You may remember, or you don't remember, of course, but at the turn of the last century, William Osler described lupus as a skin disease. And the original description of lupus was, and that's where the name comes from, the general name meaning wolf, which was determined by Kazanov, early describers, and Hargraves later, that it looked like a wolf had scratched the patient's face because of the malar rash. And so hence the term lupus and systemic erythematosus. So the original description by Osler was that it was a skin disease, often thought to be tuberculous in character. Nobody knew anything about immunology then. This is the standard band test looking at the staining of the dermal epidermal junction. Here are some of the skin manifestations. You can see there's an array of manifestations of the skin, going from the malar flush that I mentioned to Osler's or Janeway's lesions, to bullae on the palms or the feet, lupus profundus with paniculitis and loss of fatty tissue in clumps. And there's petechiae, purpura. And now you're probably saying to yourself, my gosh, all these clinical manifestations, it's so universal and global. And in the preface to the textbook, at least the last edition, I said, this must be more than one disease, because it is so protean in nature. It involves so many different organs in so many different ways. And it makes really one wonder that the common mechanism is autoimmunity, of course, but this disease manifests in so many different ways. This is typical skin of a patient. Note that the articular surfaces are not involved, as would be the case in dermatomyositis or polymyositis. These are not Gutron nodules. These are between the articular surfaces. The articular surfaces of the MCP and PIP joints are clear. And here is the typical malar rash. And here you see some of the telangiectasia and the little ecthyma-like lesions on the fingertips of patients. Discoid lupus, this is typical for African-American patients. The only treatment we have for discoid lupus at the present time is, of course, Plaquenil or hydroxychloroquine being the #1 thing, and it's treated topically and sometimes with topical injections, but it's very, very refractory to therapy. This lady, this is a malar rash, and she was treated with retinoids and did very, very well. So that is one of the options we have in treating lupus skin disease. This is lupus profundus. The treatment of lupus profundus would be more dapsone and related drugs. This is fortunately very rare, but it does occur. Hematology, autoimmune hemolytic anemia, various autoantibodies, including autoantibodies to stem cells, and of course, antiphospholipid syndrome. What are antiphospholipid antibodies? The lupus anticoagulant, antibodies to cardiolipin, and the biological false positive test for syphilis. The lupus anticoagulant consists of and have criteria for thrombosis, thrombocytopenia, recurrent abortions, and the false positive test for syphilis. What is the classification? And this is from Wendell Wilson. We actually devised these. I was part of this group in Sapporo, Japan. We had the phospholipid mafia meeting, which occurs about every 4 years. And the phospholipid mafia meeting are all of about 20 people who are interested in procoagulant states. And it's a good group, but we came up with these criteria, which included venous arterial small vessel vascular thrombosis, Pregnancy morbidity, 3 or more consecutive abortions less than 10 weeks, 1 or more fetal deaths greater than 10 weeks, 1 or more premature deaths less than 34 weeks because of preeclampsia or placental insufficiency. And of course, you need the anticardiolipin antibody or the lupus anticoagulant on 2 or more occasions, 6 weeks or more apart. Patients have been anticoagulated and treated for not having antiphospholipid syndrome. So that's why we say 2 or more occasions, 6 weeks or more apart, to make sure you don't give somebody heparin or Coumadin, wind up having them fall over and have a subdural, and wind up really in court trying to explain why you gave an anticoagulant to somebody who only had fleeting antiphospholipid antibodies. This is the beta-2 glycoprotein or cofactor. We measure beta-2 glycoprotein 1 IgG, A, and M. And I won't perseverate on this, but this is a very important cofactor to measure and probably is more associated with predicting thrombosis than anticardiolipin, for example. The major manifestations are peripheral arterial and venous thrombosis, stroke, fetal wastage, myocardial infarction in young people, microangiopathic renal failure, which I already talked about, Budd-Chiari, which I've seen only 1 case in my life, and skin and mesenteric and graft thrombosis, which I'll show you in a second. The minor manifestations are low platelets, avascular necrosis, lividoreticularis, and Raynaud's, which I'll show you. So this is thrombosis, and this was actually a patient at Roosevelt who did very, very poorly. She had a GI bleed, and when she was at Roosevelt, the GI people dropped a line in and gave her an alpha blocker, which resulted in a very, very bad outcome. She thrombosed all 4 extremities. To the right of this hand is a patient, a different patient, who had infarction of the skin with antiphospholipid syndrome, who had biopsies of the skin to show the thrombi at the edge of the infarct. This is lividoreticularis, or in some cases you might call this lividoracemosa, which is the worst form of lividoreticularis. But you have to have your room temperature low in order to really see this as a skin manifestation of lupus and phospholipid syndrome. This is, of course, not specific to phospholipid syndrome, but it would indicate if the patient has any clotting abnormalities or a history of miscarriages, et cetera, they should be worked up for lupus anticoagulant and get the panel of anticardiolipin, IgG, M, and A, and phospholipid cofactor, beta-2 glycoprotein, IgG, A, and M as well. Young lady who had both clotting and bleeding at the same time. It's a patient from St. Luke's. I don't know if any of you remember this. She had bleeding, she had ecchymoses, she had an anti-factor 8, as well as a number of clots during her pregnancy. And she was carried to term with judicious hematologic workup. It was Harvey who helped manage his patient. Harvey Weiss. And you all remember Harvey, those of you of a certain age. And this was a great save. This is a lady who's on her treadmill and noticed that her right arm became numb. She had antiphospholipid antibodies, and the arrow is pointing to the thrombus, which was promptly removed. Not uncommon to have that happen with patients that have phospholipid antibody. And this is one of my favorite patients who's lost to follow-up, who clotted off his inferior vena cava, which again calcified, the clot finally calcified, and he developed wonderful collaterals on his abdomen, which I have there pointed out with arrows. He was also a patient I saw at Roosevelt, Roosevelt Hospital, which is now Mount Sinai West. I apologize to all the Mount Sinai folks. This is a lady from St. Luke's. You may remember this. I think Dr. Braun, Carl, I think you saw this patient many years ago. She had the diffuse antiphospholipid antibody syndrome, or catastrophic syndrome, 17 years old. This is a CAT scan. She presented with multi-infarcts in her liver, her lung, her brain, and she actually survived. We treated her, we anticoagulated her. Catastrophic antiphospholipid syndrome is really the syndrome where multiple organs clot, and it's really a major emergency. And if you're an adult, you usually don't survive. But if you're a child and you're very, very resilient, you do. Cardiopulmonary manifestations can be very varied, associated with antiphospholipid syndrome, pulmonary hypertension, Raynaud's of the lung, if you will, pulmonary vasculitis, and interstitial lung disease. Very, very familiar looking to what we're seeing currently post-COVID-19. And this is an example of what you typically see in slide A is the pulmonary effusion. You see vegetations, you see pulmonary emboli. I'm going to move along fairly quickly. You can see Libman sacs these days with us doing echoes on everybody. You see the arrows pointing to the thrombotic vegetations. These are not infected, but they are merely thrombotic vegetation from a phospholipid patient. And this is from our textbook. Now, the peripheral central psychiatric syndromes abound in lupus. Amazing. Over 67% of patients with lupus have psychological or psychiatric manifestations. Seizures, 8 to 20%. Cranial neuropathies, common. Peripheral neuropathies, very common. And one has to differentiate the peripheral neuropathies from that seen in diseases like Sjögren's syndrome. I see a lot of Sjögren's with peripheral neuropathies. And by the way, I have a huge practice. You're probably saying, well, what's he talking about? He's chairman of medicine. But I've taken 2 days of the week in the afternoons to see patients just with rheumatology in the clinic. And I see all of this stuff. Migraines, very common. Chorea, I collect patients with chorea that have Sydenham's chorea, number one. And secondly, have chorea and hemibolismus from antiphospholipid antibody syndrome. We saw a transverse myelitis yesterday with the residents in the clinic. Very, very exciting to see. And of course, organic brain syndromes and psychosis. So transverse myelitis, while unusual, is not super rare. Primary neuropsychiatric systemic lupus, there's vasculopathy. There are autoantibodies, antineuronal, anti-ribosomal, antiphospholipid. When there's primarily vasculopathy and antiphospholipid antibodies, there's focal neuropsychiatric disease. There's diffuse disease when we suspect inflammatory mediators are at their high. And you have concurrent non-lupus neuropsychiatric disease. This is a slide that's kind of confusing, but we made it up to try to explain the difference between diffuse neuropsychiatric and focal neuropsychiatric or neuroperipheral disease. This is UBOs. This is also very common, and I think somebody, maybe Carl, you defined the term UBOs in the old days when we would see patients that had no central nervous system findings, but on MRI, you saw these lesions, which we call unidentified bright objects, UBOs. Very common. This is a guy with trichotillomania who plucked his hair and his pubic hair and ate it and wound up with a trichobezoar in the hospital, had neuropsychiatric lupus. This was from Rockefeller University. And there's miscellaneous infarcts of the bowel, the arthritis of lupus, which is non-erosive for the most part, which occurs, this is PIP joints, which are swollen and often fluid-filled. These are the findings when you do and we do retinal exams on every patient that we see, and we see these cytoid bodies in many patients. Jacquard's arthropathy, non-erosive again, with swan necking of the fingers, typical for systemic lupus, and patients with rheumatic fever, for example. Myositis, very limited myositis in lupus, not as profound as in dermatomyositis or polymyositis. The myositis of lupus is a CPK, say, of 1,000 to 2,000, not off the wall. And the oral ulcers, which are seen in the palate, which are non-tender, to contrast them to patients with Behçet's disease, who come in with very, very painful lesions in various parts of their bodies, but also their mouth. The basic treatment for systemic lupus, going to treatment right now, and I think we may get through the slides so we can have questions. Non-steroidal therapy for fever, arthralgias, myalgias, but one has to be careful with NSAIDs and renal function in patients with lupus. Very, very important to note. Glucocorticoids, antimalarials are used in basically everybody, especially those with antiphospholipid syndrome. We use azathioprine to carry patients forward after cyclophosphamide. We use cyclophosphamide with kidney, lung, CNS, and hematologic disease. And we use the cyclosporins in certain forms of glomerulonephritis, where I mentioned that these drugs are useful, and dapsone in lupus profundus, which I also mentioned. Now, mycophenolate or Cellcept is useful in the treatments of patients with lupus. The major side effects are GI. The usual dose we use is 2 grams per day PO. It's useful in diffuse proliferative disease, acute cutaneous lupus, and discoid lupus. Here's a before and after with Cellcept. This is subacute cutaneous lupus in the before, which is very, very profound, and it responds beautifully. And here's another case before and after with Cellcept, 2 grams a day, 1 gram PO BID. Antimalarials, well, this has gotten a lot of press, and I gave this at the Abu Dhabi Advanced Rheumatology Review a few years back. And we know that it reduces platelet aggregation, lowers blood glucose, lowers cholesterol, positive effect on bone mineral density, possibly being researched right now, has antibacterial, antifungal, and antiviral actions. And this is where they got all this stuff before everybody was, and their brother was on Plaquenil or hydroxychloroquine. And you can see that it does reduce platelet aggregation. And Lancet had an article about COVID-19 patients taking baby aspirin and having a 47% decrease in mortality, I don't know if I can believe it, with patients on baby aspirin. And hydroxychloroquine will do the same thing. It also inhibits toll-like receptor activation, endosomal acidification, which was one of the mechanisms. And by the way, this slide predates COVID by many years. It's the endosomal acidification was one of the proposed mechanisms for its activity in the lung and preserving the alveolar cells in COVID-19 infection. Subsequent to everything has been proven by the FDA and others to be of uselessness in COVID-19 infection. What are our indications for cytotoxic agents? Well, involvement of major organs, obviously. Failure to respond or inability to taper corticosteroids or use acceptable doses for long-term use. The specific organ involvement we've already gone over. I'm not going to dwell on this because I do want to get to some of the newer agents. So here they are. What we use now in the treatment of lupus, does this pointer work? Can you see my pointer, anybody? Just signal that you can.
Yes, yes.
All right, great, thanks. Inhibition of B-cell survival. This was from Nature Rheumatology, I believe. I published this with Wen Zhang. We made this slide. Anti-BLyS is anti-B lymphocyte stimulating factor, and anti-BAFF is the same thing. These are really things that promote apoptosis of autoreactive B cells in lupus, and is given intravenously and more recently subcutaneously on a weekly basis. Over here, B-cell depletion. This is Rituximab and other agents. Inhibition of co-stimulation. This would be abatacept. We use that. We can use that as well. Hold on. And over here, cytokine inhibition. Anti-TNF alpha we don't use. Anti-IL-10, possibly an certain anti-interferon is being looked at right now for use in treatment of patients with systemic lupus. Oh, this will pass. The B-cell basis for therapy, and here's belimumab and atacicept. These are the two latest biologicals. This one is being approved or up for approval by FDA right now. Belimumab has been approved and is the one we use. And of course, up here, CD20 inhibitor is rituximab, which is the drug that I like to infuse in patients who are recalcitrant. I most recently used this on a patient with IgG4, which could be another grand rounds, Yusuf, that we can give, IgG4 syndrome and related disease where the patient had autoimmune pancreatitis, and giving rituximab virtually cured him. It's amazing. I'll pass on this. B-cell depletion obviously is where we want to be. This is rituximab and why it failed in 2010. Why it failed because there was no significance as seen by the FDA, but in fact we all use it. It is not approved for use in systemic lupus, but we use it as a treatment because it is quite effective. It's just that the clinical trial was designed in such a way as to indicate that it was non-specific as an overall response for both chronic renal and acute renal failure. And Bliss is the member of the TNF family that I just mentioned, B lymphocyte stimulating factor. There are, as you see here, 3 receptors. All of these receptors, TACI, BCMA, and BAF, are being utilized now to develop more drugs that inhibit unrestricted autoreactive B cell production. So it's a very exciting field. This is normal B cell development. And you see B cells in naive tissue, cellular collaboration, co-stimulation. And here's from the germinal center of the B cell, there are long-lived plasma cells down here, memory cells. All of these in rheumatologic ways are important and effective in the production of autoantibodies that produce the immune complexes, anti-DNA antibody. And here B cell dysregulation is a contributing factor in lupus. So you have this autoantigen, whatever it is, which results in autoreactive memory B cells, which persist in the circulation, and autoreactive plasma cells, which produce autoantibodies. So our target right now is to go after these B lymphocyte stimulating factors. And what belimumab, the monoclonal, does is binds to soluble B lymphocyte stimulating factor, and it removes that. And in some patients, not all patients, they get a beneficial effect. And there's recent data coming out showing that it is effective in renal disease. But that's just been published, I believe, in the New England Journal about 2 weeks ago. So I'm going to move on, and I'll say, oh, we're finished. So basically, you see, and I did get finished in time for questions, you see that this is a very complex and very protean illness, for one thing, presenting in many different clinical ways and treated with many different drugs, depending on the clinical manifestation. And in the textbook, again, we have a whole section on therapy, because there are so many therapies that are old with non-indications. There are some that the FDA have approved, among them hydroxychloroquine, which is used routinely in lupus and rheumatoid arthritis. I think the whole world knows that now, and phospholipid syndrome, of course, because of COVID-19. And I'll stop here and open the floor to questions. Don't forget to unmute yourself.
Yes, hi everyone. So if you want, just unmute yourself and just pose your questions, or you can always write them on the chat and I'll read them for you in case your mic is not working or having other problems.
Bob, one presentation, my gosh, I feel overwhelmed, but it always makes me think that disease we don't see anymore, but has so many features that are not dissimilar to some of the syndromes of lupus, is rheumatic fever. So
yes.
You know, depending upon the strep strain you were infected with, you either got carditis, chorea, or nephritis. So it seems to me that there's an inciting organism. Here's a fairly large bacterium, strep, but depending upon its type. So I wonder with the genetic factors, why some people have a shared protein with organisms, which then trigger this autoimmunity as a response to the organism, because you're trying to fight the bug that's killing you, but you wind up killing yourself in the process. So there are similarities, and it must be true in everybody to some extent, but the people who clear it then don't go on to have chronic disease, whereas the people who can't clear it do. So what keeps it going? What's the fire that keeps it going instead of shutting it off like we do, like a normal resolution of infection does?
Well, it's clearly, Norma, your immune response genes. I mean, we've been saying that over and over, and it has become of great importance in the last 6 months with COVID. We suspect that immune response genes vary from individual to individual. And in fact, there's a guy at Rockefeller that I know who is looking at what are called inborn errors of immunity. And those inborn errors of immunity, and he's gone out and studied families where there have been multiple members, and you've all seen this in the news, multiple members of the family. In fact, we had a family here in Freehold, New Jersey, where they were infected at a family event. I don't know if it was a barbecue or a dinner, and all 5 of them succumbed to the disease. 3 of them wound up on ventilators in the ICU. So what What is it about the genetics, the immunogenetics? Clearly, from what you see with lupus, there are markers and there are cofactors and there are epigenetic effects that predispose certain individuals to a really ratty innate response and maybe even a depressed adaptive response. The adaptive response is the subsequent antibody-specific response, but the innate response is the one that's right up front. And that may be defective in some people, because with a viral infection, that's what counts in the early days. And so with streptococcus,
it appears Dr. Lahita has poor connection. He was very good during the talk, but now just froze.
Can you send him a message or something, David?
Let me see.
Or text him or something?
At least it was at the end.
Yeah.
Let me see.
Those New Jersey connections.
Signal has to go through the tunnel, right?
But Bob, it's actually the GW bridge, not the tunnel.
Oh, yeah.
Dr. Lee, actually, I don't have his phone. Do you mind calling him? I don't have his cell phone.
I'm not sure I do it myself, actually.
I'll use this moment to remind people when you ask questions to state who you are, what division you're in, and where you see patients, please. Again, it's a way for us to continue to familiarize each other with our roles and opportunity for collaboration.
Hi, Sam. It's Robin Lipschitz here. I was just going to direct this at Yusuf. It was interesting that Bob didn't mention the role of tacrolimus, which we often use as an alternative to mycophenolate in the difficult to treat cutaneous manifestations of lupus, the paniculitis, etc. What do you think about that?
Yeah, and there's some new data with calcineurin inhibitors as well for lupus nephritis, which is just coming out hot off the press from the ACR. And, you know, we really don't use much Cytoxan anymore, to be honest, unless they have very severe refractory disease. I mean,
right. There was another important point that I would raise, that when folks are using cyclosporine in particular, it's very important, particularly for the nephritis patients, to be aware of accelerated hypertension. And it does have quite, you know, potentially severe effects on renal function.
did I see Mike Mullen on this call? All colleagues from St. Vincent's, I think.
Yep.
Is that Mike?
Yeah. Hey, Yosef. How are you?
How are you?
Good, good. Miss seeing you. Now that you're over in Cam, you know. Are you still there on Mondays?
I'm there. We moved to 102nd Street.
Yeah, that's what I mean, Campbell.
Yeah, yeah. But I was going to ask you about what vaccinations we should be doing in our lupus patients, or immunizations, because it's a primary care audience.
Well, I think, you know, you should probably go by the recommendations, vaccine recommendations. I mean, nothing unusually. We really haven't been giving anything more than pneumococcal and flu. And, you know, if there's spleen dysfunction, then sometimes we do the meningococcal vaccines. But other than that, no, I don't think there's any.
How about shingles, the Shingrix?
Well, of course, shingles is like, you know, that's anyone over 50 should get that. Yeah, because it's not a live vaccine. So
yeah, we get some pushback from our younger immunosuppressed patients under 50 from insurance because they won't pay for it.
No, they won't. They won't. They're just paying now. Sometimes they won't pay for someone over 50. So you really have to fight it occasionally, but it's getting better.
Yeah.
Can I speak?
You,
Oh, okay.
I think he's joining. We just came from a ACR rheumatology meeting where it's similar audio-visual issues, but some challenges. But some people calling in from internationally, and they had great signals. So it's just weird.
could be peripheral thrombosis. Yusuf,
true,
maybe you can respond to my question in the chat, Yusuf.
Oh, sorry.
Can anyone hear me? Oscar Garfine?
Yes.
Hi, Oscar. Yeah.
I just wanted to, first of all, I'm sure as we all felt, this was a simply spectacular lecture on the current state of lupus, and it was very humbling to know, at least from me, from my point of view, how much I didn't know. And Bob is sort of, I guess, one of the world's experts on this. But on a personal note, he is a man, as you could probably tell from his talk, a man of unbounded energy. And during the 9/11 episode, he organized a flotilla of boats coming from New Jersey to southern Manhattan to help people out. I think he's director of emergency services. Bob, Oscar Garfine.
Oscar, welcome back.
Hey, I haven't heard and seen Oscar in ages.
Right.
I don't see you.
I was just commenting that the talk was spectacular as usual, but I was really upset at the palpable decrease in your energy level over several years. So it's very worrisome thing. But it really was an amazing.
Thank you.
Talk. And I just told everyone about your organizing it flotilla at 9/11.
Oh yeah. Thank you. We're going to celebrate the 20th anniversary this coming year, 2021. I have all the paramedics and all the EMTs, which will go to the Hudson River and throw roses into the river. We're already planning it because it was such a monumental event, unforgettable.
Yes, yeah.
Sort of like the pandemic.
Yes.
So I was talking to Norma about immunogenetics, and that's what we think is going on. And Rebecca Lansfield, bless her, when she was still alive, I used to have lunch with her. And she also, in those early days, agreed that for streptococci, that the immunogenetics of individuals was very different. And depending on what kind of immunogenetics you had, you would get rheumatic fever or not have rheumatic fever after a strep infection. But gee, I want to connect with you, Oscar, after this is over. I have to, there's so much to talk about. Holy cow.
Bob, someone asked in the chat about early red flags for lupus and what should the internist or generalist think about and be watching for?
Well, let me say that what the general internist should be looking for, and it's very, very protean as a disease, is malaise, joint pain. Those are the ones when I showed the Toronto cohort list of morbidities. Fever sometimes, low-grade fever. If the fever's above 101, it's not lupus. Usually it's about 100.5 to 100.2 degrees Fahrenheit. So those are the kinds of things. And now post-COVID, I have a lot of my residents who have come to me with joint pain and positive ANAs. Believe it or not, it's really extraordinary. And these are males and females. So there's something going on here. And there's a paper, as I mentioned, that was on, I believe in Nature, it was either Nature Medicine or Nature Rheumatology, where the authors described a very similar syndrome.
And any clues about getting people off steroids? That's the other big problem I think we see.
Well, yes, we try to get them off steroids as much as possible. And I've actually gone to methotrexate as a steroid-sparing agent in those patients that don't have active renal disease. Of course, belimumab is very effective now that it's sub-Q. You can give that 200 milligrams a week subcutaneously, and you can get your patients tapered off of steroids with a nice program, either every other day taper, or depending on how long they've been on steroids, using either 5 milligram decrements or 2.5 milligram, or using actually 1 milligram decrements. And I go down over a period of weeks to 0. But I always back them up with something, either be it Plaquenil, Imuran, or as I said, methotrexate. I've actually used Xeljanz, which is a JAK-STAT inhibitor, in a number of patients as well. And we're very effective in lupus.
Dr. Lahita, thank you for a great talk. I'm Bahar. I'm one of the rheumatologists at Mount Sinai Hospital. I had a question about mortality in lupus. You showed the Bernatsky data from 2006, and I think that extends until 92. And you mentioned that, more contemporary cohorts, both the Toronto cohort clinic and High and Choi's data doesn't show that there's any evidence in improved mortality. What do you think is a missing piece? We always talk about, well, we don't have as many drugs as we have now in RA, but I'd like to think we're a little bit better in picking up disease early and seeing our patients more frequently. And we know cardiology is so much better over the last 20 years in treating cardiovascular disease. In your expertise, what's the missing piece here, and what should we do?
Well, we talk about long haul, which is the effect of whatever the acute infection or whatever is the trigger of lupus is. As the patients go forward, we know that there's increased morbidity with the use of steroids and other things. But let me tell you something. Is it by here? Compared to what it was in the 70s and in the 60s when I was a medical student, believe me, we've come a long way with regard to mortality in this disease. There was a time in the 70s, I remember, when I was at Rockefeller as, well, I guess I could be called the chief resident at the time. I took care of almost all the patients in the research hospital, and they used to die all the time routinely from lupus, lupus nephritis, lupus cerebritis. Nobody really survived. So you're right that the missing link right now is our ability to make the diagnosis early. There's still patients who are taking up to 5 to 15 years to be diagnosed. I have specific examples of that. So doctors are not diagnosing. Everybody is doing autoantibody testing. I'm seeing patients, I'm sure you are too, being sent with positive ANAs that clearly don't have lupus. ANAs are not the end all. It's a very non-specific test. The patient needs to be totally examined and has to be managed from day one with immunosuppression. Even mild disease. And I think our mortality has decreased significantly. Is that the question, that kind of answer that you wanted, or am I missing something else?
Well, no, kind of. I mean, like, our mortality has decreased, yes, since the 70s, but over the last 20 years or, 25 years, probably not as much. And I think we're a little bit more liberal in treating with immunosuppressants because same data shows that we are using more immunosuppressants. But I think you're right. It's a long haul. And maybe I'll be talking in 2050 about how in the 2020s it was so bad.
Well, we have to go to the molecular targets, and you saw some of those with BAFF and TACI and some of the B lymphocyte stimulating factors. And we also need to go to the T cells and look at T cell modulation and control.
Yeah.
And then, of course, the dendritic cells, with hats off to the late Ralph Steinman, who studied dendritic cells in my patients when I was at Rockefeller. Ralph, as you know, was the dendritic cell discoverer who got the Nobel Prize actually 3 days after his death, which is unheard of. But Ralph was an amazing person, and he felt that the dendritic cell was the key to autoimmunity, the key to lupus, plasmacytoid dendritic cells, which may or may not be the case, but we still need a lot of research in this area. I think actually COVID-19 is giving us a lot of clues that we never had before.
Thanks.
Sure. I see Dr. Lipschitz there looking back at me. I haven't seen you in an age either.
HIV opened immunology to a great extent, and I think COVID is doing the same.
COVID is doing amazing things, yes, making us understand immunity better. I didn't mention the fact that we use cytokine inhibition in COVID, like tocilizumab, IL-6, IL-1 inhibitors, and they've been very effective. Or modestly, I shouldn't say very, moderately effective.